We open in the early 1990s, when a silent emergency was unfolding in the crowded, dusty barrios of Lima, Peru. Tuberculosis, a disease once on the retreat, had returned in a form doctors feared most: multi-drug resistant TB, or MDR-TB. The drugs that might cure it existed, but they were expensive, complicated to administer, and, according to prevailing international policy, too costly to offer widely in low-income countries. The World Health Organization and many global agencies had concluded that, given the risk of failure and the expense, treating MDR-TB in poor communities was not a feasible public health investment. Patients were written off as lost causes. Into that moral vacuum stepped a small nonprofit called Partners in Health, founded by a handful of determined clinicians and activists. They refused the calculus that placed price tags above human lives. Their premise was simple but radical. If people are sick, they should get the best possible care, no matter where they live. This conviction would set them on a direct collision course with international guidelines and entrenched institutional reluctance. The early work was painstaking and improvised. High-quality second-line TB drugs were tightly controlled and prohibitively expensive. Partners in Health could not simply order cases and expect bureaucracies to follow, so they improvised supply chains, bending rules and exploiting loopholes. They negotiated with sympathetic pharmacists, forged alliances with suppliers, and found legal routes to import drugs that had never been intended for the neighborhoods of Lima. In a sense, they smuggled hope into places where hope had been rationed. At the same time, they restructured the concept of care delivery. Instead of relying solely on distant physicians and overburdened clinics, Partners in Health trained local residents, neighbors, relatives, former patients to become health companions. These companions learned to administer complex drug regimens, observe patients through long courses of therapy, and support them through side effects and social stigma. The companions did more than deliver pills. They brought meals, accompanied patients to appointments, counseled families, and created an accountability rooted in community ties. That approach was deliberate. Partners in Health believed that medical knowledge alone could not cure MDR-TB. The social determinants of health poverty, hunger, isolation had to be addressed in parallel. Treatment was combined with food support, home visits, and education. The model reframed adherence not as a patient's responsibility alone, but as a communal project. Neighbors became caretakers, and clinics became hubs of a larger social response. Skeptics abounded. Critics warned that using expensive drugs in poor settings would breed more resistance, or that the initiative would be unsustainable. Funding was precarious, logistics were nightmarish. But as months became years, the results spoke louder than the debates. The cure rates achieved in those Peruvian neighborhoods were astonishing, consistent, measurable, and far better than predicted. Patients who had been declared hopeless recovered. Relapses dropped, mortality plummeted. These outcomes forced a reckoning. Hard data, compiled by Partners in Health and their collaborators, could not be dismissed as anecdotes. The World Health Organization, confronted with empirical evidence of feasible, effective MDR-TB treatment in resource-poor settings, began to rethink its stance. The implication was unignorable. Policies rooted in cost-based triage were costing lives unnecessarily. Eventually, the success in Lima became a catalyst for global change. International guidelines were revised. The WHO undertook a comprehensive overhaul of its MDR-TB treatment recommendations, embracing community-based care, broader access to second-line drugs, and support systems that addressed social factors. What began as a defiant local experiment had become a blueprint for global practice. The arc of this story is not just about medicine. It is a study in moral clarity, logistical creativity, and the power of community. Partners in Health showed that when people refuse to accept the limits imposed by policy, and when they match clinical rigor with compassion, the rules themselves can be rewritten. In the end, the cure rates were not simply clinical victories. They were proof that health equity is not an ideal. It is a practical, attainable mandate when courage and care converge.